Hello and welcome to our infection prevention grand rounds. Our topic today is tuberculosis, a persistent public health threat, and our presenter will be Benjamin Galvan, our infection preventionist. I want to cover some housekeeping topics really quick and introduce him before he gets started. You could see in the chat box that in order to obtain CE credit, you have to attend the entire CE program. An attendance report will be downloaded from this Teams event. Please type your name in this meeting Q&A box to receive credit, especially if you're sharing a computer with somebody else. You will receive an email from me, Angela Remore, with the link to complete your evaluation tomorrow morning. You must complete this evaluation to obtain your CE credit. The deadline to complete your evaluation is by the end of business day Friday, July 22nd. You will receive an email from me on Monday with your CE certificate attached. Since this is a live Teams event, you are automatically muted. If you have any questions, please type them in this chat box and we will answer them at the end of the presentation. So let me introduce our speaker for today. Benjamin Galvan is a board-certified infection preventionist and public health professional with a background in medical technology and clinical microbiology. Galvan attended Louisiana State University, Baton Rouge, and Louisiana State University Health Science Center, attaining bachelor's degrees in both biological and medical laboratory sciences. Galvan joined TGH's infection prevention team in 2021 and currently covers several departments within the hospital, including the Centers for Neurology and Neurological Medicine, Endoscopy and Burn, as well as the Sterile Processing Department. Galvan also serves as the hospital's high-level disinfection committee chair, providing subject matter expertise and evidence-based guidance to the hospital's semi-critical device and flexible endoscope reprocessing program. In June of 2021, Galvan was awarded the inaugural Emerging Leader in Infection Prevention Award for his work in performance improvement and innovation at the National Association for Professionals in Infection Control and Epidemiology, also known as APIC, conference, the leading professional association for infection preventionists. Galvan is currently serving on the APIC National Communications Committee and is a member of the Communications Committee for his local chapter, BAPIC. Galvan is presently pursuing his master's degree in public health with a concentration in infection control at the University of South Florida. Benjamin, go ahead and take it away.
Thank you, Angela. Again, good afternoon, and thank you for joining me today. My name is Ben Galvan. I am a board-certified infection preventionist here at Tampa General, and today I'll be discussing tuberculosis as a persistent public health threat. Upon completion, participants will be able to describe what is called the natural history of disease of tuberculosis, its management and associated risk factors, list at least 3 challenges to TB eradication or elimination of TB, and recognize the potential downstream effects of COVID-19 pandemic on TB eradication efforts. So let's get into the natural history of disease. So in order to look at opportunities with disease elimination, we need to understand its natural history for the progression of disease process over time in the absence of treatment. It's also important to understand the difference between infection and disease, as I'll be using these terms frequently through this talk. Infection is the invasion of a pathogen into a susceptible host, whereas disease is a state of infection where the infected person becomes sick, typically occurring after the body is unable to keep the organism from replicating. Tuberculosis, also called TB or MTB, typically begins following inhalation or breathing in the organism by a susceptible host, which typically is anybody is susceptible to TB. For most individuals, TB will begin to circulate and ultimately locate an organ to infect. Typically, this is the lungs, what we call pulmonary TB, but maybe any other organ like the spine, brain, or kidneys. This is called extrapulmonary TB, or outside of the lungs. During this process, infected individuals are asymptomatic or have no symptoms and are generally unaware of their infection. For most, their immune system is able to keep the organism in its dormant state, and this is termed latency or latent TB infection, or LTBI, where TB is not causing any active disease in the infected host. Over the next 1 to 2 years following infection, this is when we'll most typically see infected individuals expect to transition to active disease. This is about 5 to 10% of those infected. And after 2 years, the likelihood of transitioning to active TB disease is around 5 to 10% for the remainder of their lives. And typically will occur due to a change in their immune function, something like HIV infection, or as a result of their cancer treatments. Once the transition occurs, active TB disease can be what's called insidious, meaning it can mimic other types of illnesses, presenting as fatigue, weight loss, cough, but depending on your immune status, these classic symptoms may not even be present, making diagnosis sometimes difficult in this type of population. Death will likely occur within several months to years if left untreated due to wasting, what is previously called consumption, hemorrhage, which means bleeding, and caseous necrosis of lung tissue, which I have a picture on the screen where the lungs essentially begin to look like Swiss cheese. So to review TB, I've pulled up pieces of a timeline available on the Oxford Medical Education website. So TB is an ancient disease that has been around for thousands of years. In fact, genetic studies indicate that TB has been around for at least 15,000 years, if not more, with physical evidence of extrapulmonary TB, again, outside the lungs, discovered in ancient Egyptian mummies. TB also went by other names, termed phthisis or consumption by Hippocrates in 460 BC. This was coined due to the association of weight loss by diseased individuals. However, its cause would remain elusive for many years. By the 17th century, clinical descriptions of TB would begin to emerge in literature, including the contagious nature of disease, which was suspected and written about by Girolamo Trecastoro, who wrote that TB could be spread through contaminated bedsheets and clothing of diseased persons. In 1720, Dr. Benjamin Martin was the first to suspect that TB could be caused by, as he wrote, minute living creatures spread by diseased individuals. Dr. Jean-Antoine Villemin finally demonstrated in 1865 that TB could be transmitted from humans to other animals, and that it was caused by a specific organism, which was later identified by Robert Koch as Mycobacterium tuberculosis in 1882. We then began to see the first screening test developed by Charles Manteau in 1907, which I'll discuss in a couple slides when we get to diagnosis. So, as was identified by Robert Koch, the cause of TB is the Mycobacterium tuberculosis, or again, MTB. TB is transmitted via prolonged contact, considered around 8 hours, with infectious aerosols, which are tiny airborne respiratory droplets, or much less frequently from secretions or drainage from infected wounds of those extrapulmonary sources. Incubation, which is the amount of time it takes before active disease develops, depends on the individual's immune system, as latency is dependent on the body's ability to keep the organism asleep. And there are 3 stages of TB disease considered, though we generally just discuss the first 2. The first, which is latent TB infection, or the inactive form of TB, which typically occurs after initial exposure and infection with MTB and prior to becoming active, if that does occur at all. The second stage is considered TB disease, or active TB disease, which is when the body can no longer stop the proliferation of the organism and infected individuals become symptomatic. As previously mentioned, there's about a 5 to 10% risk of conversion in the first 2 years following initial infection. Now, the third stage of TB infection, which doesn't occur for everybody, but is called a miliary TB, which is the rare form of active TB disease when the TB organism begins to infect multiple organ systems, which can certainly rapidly lead to death if left untreated. Genetics also play a major role in the risk of TB infection. In certain areas like Northern Europe, where TB has existed for a very long time, the population has developed genetic, physiologic defense mechanisms that activate in the presence of the MTB organism, potentially blocking infection. This is in contrast to areas like in India, where TB was brought in by immigrants. In this population, these genetic mechanisms don't exist, so they're much more likely to actually become infected with the organism and then ultimately lead to disease. This is an idea similar to what's called sickle cell disease, which is an hereditary physiologic mechanism that helps mitigate infection with the parasite malaria. So the same idea here. In a population where they've seen this organism frequently, like malaria, they've developed a biological mechanism to help prevent infection. So this acts in a similar way. So let's take a closer look at latent TB and TB disease. So latent TB infection, or LTBI, again, is the inactive state of TB infection, where the bacteria is essentially asleep or not replicating. It is estimated that up to 1/4 of the entire human population is actually infected and in a state of latency, with an estimated 13 million in the US alone. Luckily, the state of infection is considered non-infectious, meaning you can't pass it on to other people, so not contagious. In contrast, with TB disease, which we consider the active form, this is the infectious or contagious form of TB, meaning you can pass it on to other people if you are sick. It's estimated that only around 1 in 10 of those infected with TB, 5 to 10%, will progress to active TB disease if left untreated. So risk of progression to active TB is subjective based upon the infected individual's immune status. This can range from no immune risk factors to other risk factors like diabetes and HIV and AIDS. We'll typically see higher rates of conversion from LTBI to active TB disease in these types of patients because their immune systems can't keep the bacteria asleep. You can see from this chart from the CDC that TB and HIV co-infections, which means an individual has both TB and HIV at the same time, presents the greatest risk of TB disease conversion or development at 7 to 10% per year, compared to 10 to 30% over a lifetime. You can see how risky it is just looking at that statistic alone. Other risk factors include people who obviously have become sick in the last 2 years. Babies and young children are certainly at higher risk for developing TB disease. People who participate in illicit IV drug activities, elderly individuals who have weaker immune systems, and then other individuals who are sick due to other immunocompromising illnesses. So back to our timeline. We begin to see treatment and prevention measures develop, including the first TB vaccination, which is called the BCG vaccine, developed in 1920, which began to be used medically in 1921. This primarily prevents neurologic infections in children. And then we also begin to see our first antimycobacterial drugs developed. In fact, the TB drugs that many of us as healthcare providers may recognize were developed over 50 years ago, with isoniazid in 1951, pyrazinamide in 1952, ethambutol in 1961, and rifampin in 1966. In 1995, we begin to see the start of what's called direct observation therapy, or DOT. This is where trained healthcare workers or other public health professionals physically observe patients who are infected with TB, take their medications to ensure that their treatment course is followed appropriately. And then we begin to see additional diagnostic tests that are developed in the early 2000s to improve TB detection. So let's get into diagnosis of TB. To start, diagnosis of latent TB primarily has to do with an individual's level of risk. I'll be talking about risk a lot with TB. And then their known exposure to TB, which I'll get into a little bit later. But diagnostic testing of latent TB and partially for active TB is done via skin or blood tests. So we have two different options. On the screen, you'll see on the left is what's called a tuberculin skin test, which is an injection under the skin that will cause an immune reaction or swelling in people infected with TB, and as well as those previously vaccinated with the BCG vaccine. Then within 48 to 72 hours by a trained professional, it would be read after the injection, and the results determined based on the size of the raised area of the skin, which is called induration. A positive test can be a clue that a person was or is currently infected with TB. On the right, you can see the blood options. So we have what are called interferon gamma release assays, or IGRAs. You may recognize these as called quantiferin or T-spot. These measure a person's immune reactivity to MTB, as immune markers are released from invaded white blood cells. This is the preferred method for those that have received a BCG vaccine, and for those that are unlikely or unable to return within that 72-hour time frame to read the skin test. So as a provider, it's important to understand and choose which test is more appropriate based on cost, availability of lab equipment and supplies. Do you have individuals trained on performing either blood collection and running the blood test, or do you have them trained and available to perform the skin test? And then how likely is someone to return for the second visit? That can play a significant role in actually identifying somebody with TB, and it's not useful if they don't actually return. And then as a side note, it's also important to understand that for immunocompromised patients, particularly our AIDS population, these tests rely on the person's immune system to mount an immune response. And for AIDS patients, this is often not going to be the case, depending how far along in their HIV disease progression is. So looking at diagnosing active TB disease, clinicians utilize a broad array of symptoms, imaging, and lab testing to determine a diagnosis. This is important as individuals with TB may not have all expected symptoms, test results, or imaging results. So it's really based on the risk between the three. So looking at active TB symptoms, this can include cough, especially one that's lasting for 3 weeks or longer, with or without sputum production. They may be coughing up blood, which is called hemoptysis. Chest pain, loss of appetite, which can lead to unintentional or unexplained weight loss, drenching night sweats, unexplained fever, and fatigue. As you can see from the list, these, aside from maybe the coughing up blood aspect of these symptoms, these are pretty general. So again, TB is considered insidious, as it's not always clear that a patient with these symptoms may have TB. Looking at imaging studies, imaging of the lungs may include findings of cavitary lesions, granulomas or nodules, as shown on the example on the screen. Cavities are walled off air-filled spaces within the lungs, observable through X-ray and CT, that are thought to occur as a result of the immune system walling off the mycobacteria in the lungs. And just think about this in terms of those that are immunocompromised, like our AIDS population. If cavities as a symptom or a finding are an immune function of that person's infected state, if they don't have an immune system, we're not going to see these findings on the imaging. And then lastly, looking at laboratory testing. So there are mycobacteriologic lab testing available in most labs. This includes acid-fast staining, which you can see in the top right. It's a specific staining method used to identify mycobacteria. We also have auramine rhodamine staining, which is a fluorescent stain when put under a fluorescent microscope. And then we do what's called clinical culturing, which you can see on the screen, the little tiny circular yellow colonies of mycobacteria. It's vital to include culture in diagnostics, as susceptibility panels for those anti-TB drugs can be run on the mycobacteria to ensure that infected persons don't have multi-drug resistant TB, which we'll discuss later. It's also good to note that there is molecular testing is available as well that could rapidly detect the presence of MTB and then genes associated with certain types of drug resistance. So TB management, I'm going to keep this a relatively high level, as the actual treatment of TB can be quite complex, but treatment regimens do exist for both the latent form and active form of TB. On the right, you can see what we call RIPE, or the rifampin, isoniazid, pyrazinamide, and ethambutol, which is the primary first-line treatment course for individuals with active TB, and typically spans around 6 to 9 months or more, depending on the resistance level. Whereas LTBI treatment includes variations of the drugs you see on the screen. Short-term treatment for LTBI includes some of the following: 3HP, which includes 3 months of once weekly isoniazid plus rifapentine; 4R, which is a 4-month daily rifampin regimen; and 3HR, or 3 months of daily isoniazid plus rifampin. There are long-term treatments like 6H and 9H, which are available when short-term is not feasible or available, but have certainly increased risk for things like hepato or liver toxicity and lower completion and compliance rates. I won't get into all of these specifically, but if you look at the names on the screen, essentially the number indicates the estimated number of months expected to be on treatment, and the letters indicate what drugs are used. It's important to note that treatment courses for latent TB should be tailored for anyone in known contact with a drug-resistant TB case to ensure adequate coverage, and those with HIV to evaluate drug-to-drug interactions. Active TB disease treatment should, in general, be the same for HIV and co-infected individuals as those without HIV, but taking into consideration, again, drug-to-drug interactions with anti-HIV medications. Keep in mind, treatment is truly based on the number of doses taken, not the number of weeks or estimated months on treatment. So non-compliance is certainly a cause for concern and may lead to a prolonged treatment course if not done properly. Ultimately, resolution is based on, first, your compliance with your course of treatment, your symptom review, any imaging tests that are available, as well as clearance of the organism from clinical specimens. Oftentimes, the Department of Health will play a role in ensuring an individual has cleared the infection, often through case management with the local TB clinic in your county. So getting into TB prevention, prevention of TB requires a multi-pronged approach involving prompt diagnosis of high-risk populations and initiation of appropriate treatment, the use of transmission-based precautions and engineering controls. Other prevention strategies include implementation of safe travel practices for vacationers and immigrants, including screening of high-risk individuals traveling from high endemic areas or areas where TB exists at a higher rate compared to the US. Vaccination in certain countries and populations with BCG, particularly for at-risk children. Public health control measures related to the control of outbreaks, including contact tracing and treatment monitoring with that direct observation therapy, as well as obtaining funding for TB clinics and TB case management. And lastly, understanding the social determinants of health in order to address inequity in healthcare to aid in the identification and management of known cases. Getting a little bit into the transmission-based precautions and engineering controls that we would see in the healthcare setting. We would use these to prevent transmission to our team members, other patients, and visitors. This includes the use of airborne isolation rooms, which are called AIIRs, that are designed to pull air into the room and filter contaminated air outside the facility. We also use control measures to verify that the room has negative pressure, meaning the air pressure in the room is causing the air and those airborne particulates to be sucked in rather than blow out compared to the surrounding environment. Additionally, we use special equipment called respirators or N95 masks that are designed to create an airtight seal, therefore blocking the bacteria from getting in while we breathe. And we'll also use certain signage like the airborne isolation sign on the screen to ensure that those providers seeing TB patients are aware of their isolation status and know what type of PPE they need to wear. Healthcare facilities also conduct what is called an annual TB risk assessment and control plan. This risk assessment includes collaboration between facilities management, infection prevention, the clinical laboratory, infectious disease physicians, and occupational health, and is a way to evaluate your facility's level of risk for TB transmission within your community as well as within the hospital itself. This assessment looks at numbers of exposed team members over time, their conversion rates, meaning have they converted to potentially infection, numbers of infectious patients within the facility, local, county, state, and nationally. We would also review the numbers and locations of our airborne isolation rooms, our annual screening and respiratory fit testing program, and our laboratory processing and capabilities to see how quickly can we turn around a clinical specimen that's suspected of TB. Facilities will also typically have a policy or procedure that includes the process for isolating and testing for active pulmonary TB. I also want to add that because healthcare workers are at particular risk for transmission of TB, the CDC has created specific recommendations that you have likely participated in at some point, which includes point of hire testing, which includes individual risk assessments of symptoms prior to diagnosis, as well as a history of BCG vaccination, treatment of latent TB in most, if not all, for healthcare workers, serial TB screening, most often annually in the absence of exposure or ongoing TB treatment. For those healthcare workers with LTBI that are untreated, they should receive yearly symptom review and education. Again, we'll be conducting that annual facility risk assessment. Exposure evaluation in the event of an active TB case that is identified would be conducted to identify those at risk for transmission. And then the annual TB education for everyone, including information on risk factors, signs and symptoms, infection prevention policies, procedures, and options for LTBI treatment. So in the last leg of our timeline, we see additional molecular tests launched in 2010 and 2020. The FDA approves treatments for both MDR, or multi-drug resistant TB, and XDR, or extensively drug-resistant TB infections. Vaccine research is unveiled in 2019. This includes a promising investigational vaccine candidate called M72AS01E that has shown promise in adults and adolescents. And then the NTB strategy was initiated by the World Health Organization. The WHO, or the World Health Organization's NTB strategy, aims to end the global TB epidemic and serve as a blueprint for countries to reduce TB incidence by 80%, deaths by 90%, and eliminate disastrous costs for TB affected individuals by 2030. The strategy includes 3 primary pillars, which are integrated patient-centered TB care and prevention, like early diagnosis and treatment for all, those kinds of things. Bold policies and supportive systems created in collaboration with governmental organizations, community stakeholders, and private stakeholders that will help strengthen and support and address those social determinants of health that we'll get into. And then intensify research and innovation aimed at improving everything we've talked about. So our diagnostic tools, our treatment options, and then how we prevent new TB cases. You can kind of see from the timeline that it stops where the COVID-19 pandemic began. So what's next? So now that we have an understanding of natural history of TB disease, its diagnosis and its management, let's look at some of the challenges associated with eradication of TB. So in order to understand the challenges, we need to understand our current state. So let's look at where we are currently in the United States. The most recently fully published data is from 2020, though there is preliminary 2021 data that I'll get into. But in 2020, there were 7,174 reported TB cases. That's a rate of 2.2 cases per 100,000 population. And it's estimated that up to 13 million people have latent TB infection. If we look at the incidence rate of change, we see a significant drop, nearly 20% from 2019 to 2020. While this data certainly looks promising, there is significant speculation regarding if this was a true decrease in cases or a result of the pandemic leading to reduced diagnosis and reporting. So overall TB incidence in the United States for 2020, there were 43 states, including Florida, reported incidence at or below the national average of 2.2 cases. 6 states and 9 cities reported incidence above national average, and there was 1 state that had no cases at all. For TB incidence among US-born persons in particular, 21 states and 1 city met the 2025 national target of 0.4 cases per 100,000 US-born individuals, which is great. 14 states were short of the 2025 target, but reported incidents at or below the national average of 0.7 cases. And then 14 states and 8 cities, including Florida, were above the national average of 0.7 cases per 100,000 US-born persons. Looking at non-US born in 2020, 11 states, including Florida, met the 2025 target of 8.8 cases. 13 states and 1 city were just short at 11.5, and 25 states and 8 cities were above the 2025 target and national average. So overall, in 2020, a little bit over 50% of TB cases were actually reported from 4 states out of the entire country, with California being around 24, Texas around 12, New York State around 8, and then Florida coming in 4th at 6% of all TB cases in 2020. So the first primary challenge to TB eradication is underdiagnosis. Underdiagnosis of high-risk populations includes those who have had previous prolonged contact with TB, people living in congregate settings like jails and shelters, people born in or traveling from high-risk endemic areas. This includes Latin America, the Caribbean, Africa, Asia, Eastern Europe, and Russia. Children living with at-risk adults, healthcare workers, and also workers in those congregate settings, which is a major concern because, as we know, if we don't know who has TB, then we can't treat it. So many of these are considered high risk because, if you remember, TB typically requires prolonged exposure to an infected individual. So these congregate settings like jails, prisons, homeless shelters, and even hospitals require prolonged contact with these infected individuals, certainly increasing our risk of exposure. For healthcare workers in particular, rules and regulations exist for the presence of many TB-related prevention measures. This includes a comprehensive screening program, and then healthcare workers would include inpatient and outpatient settings like acute care, as well as sleep study clinics, clinical laboratories, or public health laboratories. Those that work in respiratory therapy that are high risk of aerosol generating procedures, emergency medical services that are going to be the first people who see these infected individuals, certainly clinics and correctional facilities and homeless shelters, as well as those that work in home health and long-term care. According to the CDC, it is estimated that over 30% of LTBI cases go undiagnosed, which means that many people are going untreated as well. Considering this and understanding that nearly 13 million people are expected to have latent TB in the United States alone, that means that nearly 4 million people don't know that they have TB. If it's estimated that 5 to 10% of these individuals may convert to active TB, that means that between 200 and 4,000 people may become infectious. You can imagine that that's very concerning for public health professionals. The next challenge involves drug-resistant TB, which is a major health threat globally. Nearly 500,000 MDR or multi-drug-resistant TB cases are estimated to occur worldwide annually, including cases that are extensively drug-resistant. While MDR and XDR TB cases are relatively rare in the United States, which is fewer than 100 cases per year, their treatment comes at a very terrible price. It is very expensive and takes significantly longer to complete, up to 32 months for some XDR cases. Certainly disrupts lives and has potentially life-threatening side effects. And luckily, the number of drug-resistant cases in the United States remains relatively stable due to effective control strategies. So resistance is divided into 3 categories. That would be drug resistance, multi-drug resistance, and then extensively drug-resistant. So drug-resistant TB is an isolate resistant to one first-line anti-TB drug. Multi-drug resistant TB is defined as a strain resistant to more than one drug, plus isoniazid or rifampin. And then extensively drug-resistant TB is defined as resistance to a first-line defense drug like isoniazid or rifampin, a second-line fluoroquinolone, and an injectable anti-TB drug. Drug susceptibility testing is typically available through public health departments and the CDC. Some larger laboratories may have this functionality as well, and then some labs may also have the ability to check genetic markers for resistance prior to performing the manual susceptibility testing. On this slide, you can appreciate the significant cost of treating drug-resistant TB cases, reaching over $800,000 for one XDR case between productivity loss and treatment, as well as all the direct treatment costs that are associated with treating someone with a disease like this, including their anti-TB drugs, the required diagnostics to actually diagnose the illness, their case management and social work. A lot of time, these patients may actually be given housing to ensure that they are able to complete their isolation period. Their transportation to and from the clinic may be required, as well as potential hospitalization. Some serious side effects are also identified with the drugs used to treat drug-resistant TB, including depression and psychosis, hearing impairment, that liver toxicity, kidney impairment, loss of mobility, and some even report vision impairment and seizures. And we can also see that a major cost as well is for hospitalization, particularly for these drug-resistant TB cases. So risk factors for multi-drug resistant TB and XDR TB include poor adherence to prior treatments, counterfeit treatments, prior exposure, as well as misidentification of infection. When we're looking at poor adherence, the same theory that applies to antibiotics used to treat bacterial infections applies to antimycobacterial drugs as well. And because treatment is so long, compliance is certainly an incredibly important aspect of preventing one drug from one organism strain turning into a multi-drug resistant strain. Counterfeit treatments would be regarding certain countries where drugs really aren't well controlled as they are in the US. So infected individuals may think they're actually taking their TB regimens, but due to that poor control of pharmaceuticals, they may not be getting treated at all. Certainly prior exposure to someone with MDR TB is likely the highest risk. And then lastly, we look at misidentification of infection. This is two-pronged, as we described to me by a colleague. Sometimes patients with TB are treated multiple times for something like bacterial pneumonia that comes and goes. This can be a clue that actual cause is TB because certain drugs used to treat bacterial pneumonia may also be a second-line drug for TB, like the fluoroquinolones. But patients aren't treated long enough to actually eliminate the TB organism. The second prong to that is if susceptibility testing is not performed on the isolate of TB, we may not detect a strain of multi-drug resistance. A quote I particularly like, which was included in the World Health Organization's TB strategy playbook by Margaret Chin, who is a Director General of the World Health Organization, reads, "Everyone with TB should have access to the innovative tools and services they need for rapid diagnosis, treatment, and care. This is a matter of social justice, fundamental to our goal of universal health coverage. Given the prevalence of drug-resistant tuberculosis, ensuring high quality and complete care will also benefit global health security." She goes on to call for intensified global solidarity and action to ensure the success of this transformative NTB strategy. This plays directly into the next challenge to TB eradication, which involves social determinants of health. So the social determinants of health are the conditions in the environment where people are born, live, learn, work, and play, worship, and age that affect a wide range of health functions and quality of life outcomes and risks. Some of these social determinants include access or therefore inaccess to safe housing, public transportation, and proper health care. It can include the presence of racism and cultural discrimination or violence, the quality of education available. Are there sufficient job opportunities, and do they provide a sustainable income? Is there access to nutritious foods and physical activity opportunities? What about the presence or absence of polluted air and water? And what is the language and literacy skills of the community? Do they understand what they can do to prevent it? Understanding the social determinants that lead to health inequities is vital to addressing TB elimination, as well as many other communicable and non-communicable diseases in this country. I'll get into specific demographics of those TB cases identified in the US, but what we'll see is that TB rates continue to disproportionately affect Black, Latinx, and people of Asian descent. I'll also review rates of chronic diseases that are primarily associated with TB infection, like diabetes and HIV, which again disproportionately affect people of color, particularly Black men, and even more specifically, Black men who have sex with men. Studies also show that higher HIV rates are often related to those structural, interpersonal, and individual level social disadvantages. Essentially, it's an all in all, and essentially a system of opportunities or missed opportunities that leads to proper education or improper education, fewer job options, poverty, likelihood of incarceration, distrust in healthcare, and so on. This also highlights the benefits of what's called intersectionality, which I have a nice picture on the right side of the screen for. This is the interconnected nature of social categorizations such as race, class, and gender, as they apply to a given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. When public health is viewed through the lens of intersectionality, we are able to take a more helicopter approach to the social determinants and address disparities as they intersect rather than individual determinants. For example, rather than looking at just a specific gender or a specific race, we can look at the intersectionality of race, sexuality, and age or education, and look at that and how can we approach opportunities for improvement with that intersectionality approach to those social determinants. So in 2020, the top 3 breakdown by race and ethnicity was non-Hispanic Asian persons at around 36%, Hispanic individuals at around 30%, and non-Hispanic Black persons at around 20%, with our white population around 11%. Consistent with previous years, the majority of reported TB cases occurred among non-US born individuals, around 72%, further emphasizing the increased risk for immigrants and TB infection. We can also see that compared to our white population, 2020 TB case rates were 47 times higher for Pacific Islanders, 33 times higher for the Asian population, 9 times higher for our Latinx population, and 8 times higher for both our Black and American Indian population. When looking at comorbidities or diseases that occur simultaneously, in 2020, diabetes mellitus was the most frequently reported medical risk factor for TB disease. That was around 23%, which is the gray column, is total. Other non-HIV related immunosuppression made up around 9%, which could include chronic steroid use and cancer treatments. And among persons with TB disease in 2020 who were still alive at diagnosis, HIV status was actually known for nearly 90% of those persons with TB, and about 5% were known to be co-infected. Again, that means you have TB and HIV at the same time. Additionally, those with HIV and TB co-infection occurred in about 8% of people aged 25 to 44 years, and 6% of individuals aged 45 to 64. I also want to point out that for US-born individuals with TB, the greatest risk factor was contact with someone that's infectious with TB. You can see in the third column for US-born, which is the light blue, it's actually the highest risk. So looking at social risk factors, in 2020, 2.6% of persons 15 years of age or older diagnosed with TB disease were current residents of correctional facilities at the time of diagnosis. Again, this is one of those congregate settings. Additionally, around 2% were current residents of long-term care facilities, and then 290, or around 4%, reported experiencing homelessness within 12 months prior to their TB diagnosis. I've also included here some additional social risk factors associated with TB, the highest being excess alcohol use as well as non-injection drug use. You can see how certain risky behaviors can lead to an increased risk of TB. I think it's important as well when talking about risk to also discuss HIV. I know I've mentioned several times. So first, here are the 2019 data on HIV rates in the United States. HIV rates significantly affected people of color. with over 15,000 or 42% of cases among Black Americans and over 10,000 among Hispanic for new HIV cases out of the 35,000 that were newly identified in 2019. We can also see that not only are Black and Latinx people more likely to get HIV, we also see that gay and bisexual Black and Latinx men are the most affected by HIV, with Black gay men representing 26% of new HIV cases and 37.9% of all MSM cases, and then Latinx men representing 22 and 32.5% respectively. We can also understand how the social determinants of health come into play here, looking at disproportionate statistics, particularly for Black and Latinx individuals. So think about this. Black Americans represented about 13% and Latinx people represented about 18% of the US population in 2019, and yet they make up 42 and almost 30% of all new HIV cases. This is astoundingly disproportionate and certainly a focus for public health professionals nationwide. So identifying co-infected patients is paramount given the enormous risk of reactivation of LTBI in those patients. Again, that was 7 to 10% every year after infection. It is also very important as treatment depends on the patient's HIV medication cocktail, how they're being treated. Luckily, national guidelines exist to help providers with therapeutic management as well as case management and is a critically important aspect of care. For those patients, as they must remain compliant with both drug therapies, which can often be very difficult, as you can imagine, particularly when they're taking so many drugs. It can lead to drug-to-drug interactions, poor outcomes due to their symptoms, which requires further continued tailoring of their therapy, and then possible failure of that therapy. So you can see why the management of these patients can be extremely difficult, particularly when you're thinking about the disparities associated with those more likely to get HIV in our country. Across the world, according to the World Health Organization, there are more than 1.2 million people living with HIV and TB, and nearly 400,000 deaths have occurred as a result. Additionally, the World Health 2021 Global Report on TB showed that deaths among HIV TB co-infected patients were primarily caused by ischemic heart disease, stroke, and COPD in 2019. So let's look at TB in a post-COVID pandemic era. COVID-19 has presented some very interesting challenges to TB eradication that are still being investigated. We saw a significant drop between 2019 and 2020, but was this due to a true decrease in cases? Or was this just underdiagnosis? We know one of the highest risk factors was prolonged close contact with active cases and family members. Because of COVID, many people were not leaving their homes and possibly spending more time together. We also saw poor public health practices related to immigration, forcing immigrants to remain in close quarters for a long period of time. We know that one of the highest risk factors for TB is being an immigrant. So being in close quarters for a prolonged period of time as an immigrant certainly increases your risk. Public health resources were diverted to COVID response. So how did this affect people's direct observation therapy? And did they complete their treatments properly? Getting COVID landed many in the hospital, causing damaged lungs and prolonged use of steroid treatments. Has this placed an increased risk of infection to TB? Is it accurate that we did not have any cases in the hospital? We were very focused on COVID and not necessarily testing everyone for TB and COVID. And remember, I mentioned that short-term treatment of suspected bacterial pneumonia that recurs can be an indication of possible TB. The supply chain was certainly affected and caused limited access to proper PPE for many healthcare workers. Could this affect the number of conversions that we see over time? The last thing I'll mention is that certainly we saw a halt in research and clinical trials. This includes TB. So how will this affect research and newer treatments, particularly for those multi-drug resistant TB treatments or vaccine development? Data is already showing an increase in cases already, but I'll get into that shortly. According to the World Health Organization Global TB report for 2020-2021, COVID-19 has caused a tremendous health and social economic impact, including on the provision and access to essential TB services, the number of individuals diagnosed and notified, and the overall TB disease burden. The WHO primarily uses case notification indicators to understand the impact of COVID on TB, as case notification rates reflects the impact of that actual access to diagnosis and treatment on both the supply end and on the demand side. Between 2019 and 2020, there was an 18% drop in case notification. So based on this, we would assume that fewer people were diagnosed, but that may not be because they didn't actually have it. One can also look at the treatment enrollment for our MDR-TB, which showed a decrease by 15% in that year. Same thing as TB preventative treatment initiation, which dropped from around 3.6 million to 2.8. Spending certainly dropped for TB prevention, diagnostics, and treatment. And then lastly, looking at that BCG vaccine coverage gaps, which increased at least 5% or more in 31 countries that routinely give BCG vaccine coverage for their children. Projections for TB indicate an estimated 100,000 TB-related deaths due to the pandemic between 2019 and 2020 alone. Additionally, projection modeling indicates that both TB incidence and TB-related mortality will increase substantially after 2021. It's important to note that these projections could be underestimates as they do not take into account the impact of certain social determinants like poverty and undernutrition, which have a strong association with TB incidence rates. You can see here from this, on the left, you can see that as undernutrition prevalence goes up, the incidence of TB goes up. And then on the bottom right, we can see that as GDP per capita goes up, essentially as poverty goes away, you start to see TB incidence come down. So the guidance from the World Health Organization certainly includes maximizing remote care and support, minimizing unnecessary numbers of visits to health services, limiting transmission of TB and COVID-19 in congregate settings, supporting those TB prevention strategies in collaboration with contact tracing so we can identify those at highest risk for infection, and then simultaneous testing of TB and COVID where appropriate. I just also want to point out that there was a study and modeling report done by Johns Hopkins in collaboration with Avenir Health and the Imperial College of London, which essentially gives us the same idea that projections for TB up to 2025 are going to lead to an increased number of cases as well as increased mortality as a direct result of COVID prevention measures. What's happening now? Happily, the CDC is working diligently to address many of the health disparities that I mentioned earlier. They're working to improve screening of immigrants. They're also developing a Spanish website for TB for those that only speak Spanish. We're developing culturally appropriate education materials, which will be available to the local public as well as healthcare professionals. They're highlighting personal experiences to humanize the disease and remove that stigma. It's one of my favorites. There's a greater demographic stratification available through data that's being collected, and they've engaged with healthcare professionals and practitioners on understanding the current diagnostic and treatment options available to them. So research, like I mentioned, is being done as well. There's a couple areas that I won't get into too much, but the first is the TB-ESC, or the TB Epidemiologic Studies Consortium. It's a CDC-funded initiative that carries out observational epidemiologic research and related studies to look at improving identification and diagnosis, prevention, and control of TB. We have the TB-TC, or the TB Trial Consortium, that focuses on assessing the need for and conducting studies of new and existing drugs and their regimens used for the prevention and treatment of TB, including looking at pharmacokinetics, drug-to-drug interactions, and toxicity. We have behavioral and social science research, which is being done to understand the patient-provider relationship and effect on TB-related care, as well as understanding how other social factors influence health and treatment outcomes related to TB. And then we have the TB Elimination Alliance, which brings together community-based organizations across the United States to increase knowledge testing and treatment of TB and LTBI. Lastly, we have NEMA, which is the National Centers for HIV and AIDS, Viral Hepatitis, STD, and TB Prevention Epidemiologic and Economic Modeling Agreement, NEMA, which models epidemics and economics of disease to provide information on how to prevent the greatest amount of disease with the existing resources available. So this would certainly have a great effect. hopefully down the line on addressing particularly social determinants of health. So looking ahead, this is the provisional 2021 data. There has been an increase to 7,860 total cases, a rate of around 2.4 cases. And again, we're still estimated up to 13 million, still estimated with living with LTBI. As one of the only infectious diseases fully dedicated clinics, providing 7-day-a-week coverage and funding is certainly critical. This was described to me from a colleague who works at the TB clinic here in Tampa. Because of this, newer expensive treatments are not necessarily available to these clinics that must rely on navigating and providing decades-old drugs to patients, as well as many times these clinics provide additional services, like I mentioned before, like housing, transportation, and food delivery. Additionally, with the advent of innovative approaches to vaccine technology, there are encouraging results that I mentioned before related to vaccine technology and research. So this is how our local county is doing. So in Tampa, if you remember, the highest number of cases were coming from 4 states, which included Florida. You can see on the chart, which is available through our Florida chart system, anybody can access this, showing a statistically significant jump from 1.5 case rate to 4.0 compared to the state, which is the dark graph. So if you look at that state data, this is also increased from 1.9 to 2.3 cases. Still below the national average, but certainly a jump. Overall, the state saw an increase from 412 cases to almost 500. In Hillsborough County, it jumped from 22 to 60. The good news is that nearly 100% of cases completed treatment in 2019. Data is still pending for 2020 and 2021, but hopefully we will continue to see an uptrend in treatment completion. It's certainly time to end TB. We've been working on this for quite some time. So some statistics that I've pulled from the World Health Organization, between 2015 and 2020, we've seen an 11% reduction in TB incidence. This is unfortunately likely due to a lack of diagnosis and notification of positive individuals. And currently 47% of people with TB face disastrous household costs. As well, overall, 7.2 million people living with HIV were treated to prevent TB, which is good. In 2020, $5.3 billion were spent on universal access to TB prevention, diagnosis, treatment, and care, and $901 billion went towards TB research in 2019. Many of these numbers are certainly encouraging as we look to eliminate this terrible disease on a global scale. Each year we celebrate World TB Day on March 24th, which was the date in 1882 when Dr. Robert Koch announced he discovered the organism that causes TB. It's now more important than ever that we refocus our attention on this critically important public health topic. These are my references. Thank you.
Thank you, Ben. Great presentation. I don't currently have any questions in the chat. If somebody has any questions, you can feel free to put them in the chat, or you can feel free to reach out to Ben directly or myself, and we'll make sure to get those answered. So I'll just give it a few seconds to see if anyone has anything they want to type in before we end the presentation. And while we're waiting to see, this has been recorded. I will be putting the link on our infection prevention portal page. There's a section now for our IP Grand Rounds to where if you want to share this with other people in the organization, they can go there and actually watch the presentation there. And seeing that nobody has typed any questions, we'll go ahead and end the presentation today. Thank you so much for joining us today, and thank you, Ben, for presenting.
Thank you.